Hello, friends. Today I am starting a new series, especially for residents in community medicine. And the first video we are going to look at is on Anemia Mukt Bharat. So, this video or various parts of this program would be covered in maybe two or three videos. And this is based on original training modules that are available at this website, Anemia Mukt Bharat elearning.org. This program was launched in November of 2019. That is, it was launched just before the pandemic came. Now, as far as this program goes, obviously, we have to know that it is part of the flagship National Health Mission. But also to remember is this is part of POSHAN, Ocean. Ocean, we all must be knowing, is a Sanskrit or a Hindi word meaning nourishment. But with respect to government's programs, Ocean also stands for Prime Minister's over Prime Minister's overarching scheme for holistic nourishment. Prime Minister's over, overarching scheme for holistic nourishment. Okay, now the modules under this Anemia Mukt Bharat are test, treat, talk, supply, and dashboard. Now, if you see as a resident, you need to understand that most programs would more or less be covered under these topics. When we mean or when we say test, we need to diagnose that particular disease or condition. Then further, we need to treat it. Now, both these steps also include prophylaxis or some kind of prevention, which in this case here is the iron and folic acid prophylaxis that is given across various age groups. How, what, where, that we are going to see. Then when we say talk, we are talking about the health education or the counseling that needs to be done, and popularly this is known as behavior change communication. When we talk about the supply, we mean the supply chain of materials which would be useful for the steps mentioned above, that is supply chain and logistics for testing, for prophylaxis, for treatment, and also what would be required for the BCC process. And when we say about dashboard, we are basically talking about clarity and impartial monitoring and evaluation of how the program is performing. Introduction to this Anemia Mukt Bharat. So it is a Ministry of Health and Family Welfare program, and special focus is given on these age groups: children, adolescents, women of reproductive age, pregnant mothers, and lactating mothers. Guiding principles for this program. So, firstly, we need to have a beneficiary centered approach. You cannot expect a beneficiary to come to program. Your program should indeed reach the beneficiary, and that is beneficiary centered approach. So for example, we are talking about children. So most of the children would be school going children. So your program should be able to reach their schools and conduct all those processes which we talked about, be it testing, be it prophylaxis, be it treatment, be it the BCC, and any other steps involved. You cannot expect school children to come to your health centers, especially for receiving the iron and folic acid, or for that matter, for getting the hemoglobin levels tested. Accordingly, you need to have inclusive partnerships with various other departments, various other ministries, various other institutions, government, non government, as well as private. And irrespective of all those partnerships, the accountability remains with the program or with the system. It cannot be said, oh, it is private sector. We have given the iron, we have given the logistics. Now it's up to them. It doesn't work that way. And most importantly, for appropriate use of resources, you have to minimize the duplication of services. So just a brief about what is anemia. So obviously anemia is basically low levels of hemoglobin. What do we mean by low levels? We will see in subsequent slides. But what are the common signs as well as symptoms in patients or subjects suffering from anemia? So this is something that is no strange to us. Pallor, which is seen in lower eyelids, but also you can have pale tongue, pale and sore tongue, and also you can have that pallor or paleness in the nail beds as well as palms. A word about palms, one, that the palm color as a whole would look pale to you, but also the creases of the palms. Now, normally the creases have to be out and out dark as compared to the skin around them. But if the creases of the palms are relatively paler or their color is very close to the nearby skin, then also anemia can be suspected. There can be cracked corners of lips. In advanced cases, there would be these brittle spoon shaped nails. The subject would present with leg cramps, tiredness, low energy, lethargy, all those kind of symptoms. There may be headaches. There may or may not be accompanying dizziness. Furthermore, there can be shortness of breath. Now, this is very important, especially in school children, teenage adolescents. There will be difficulty and inability to concentrate in their daily activities, including studying, which would affect their scholastic performance. Or if someone is involved in co curricular activities, someone is involved in sports, it would affect the child's performance. Also, the immunity would be weak, so there could be frequent infections and there would be unusually rapid heart rate in these anemia patients. So coming back to the Anemia Mukt Bharat, so we have a 6 into 6 into 6 strategies. What are these 6 by 6 by 6 that we will see one by one? So first 6 stands for 6 beneficiaries. So these are the 6 categories of beneficiaries, and I'm sure you know all of them. But what is expected from a resident is that you should establish relationships when you are looking at and when you are studying and trying to learn from content like this. These children aged 6 to 59 months are basically your Anganwadi beneficiaries. Then these children 5 to 9 years are what we call the primary school children. Then we have the adolescents. Now, all our anemia programs have talked about adolescents, but mainly about adolescent girls. But here we are also talking about adolescent boys. So here we need to know a brief background that in recently conducted health surveys, like the National Family Health Survey and others, adult male members who are supposed to be the heads of our family, who are supposed to be the chief breadwinners of Indian families, who are supposed to get the first meal and maybe the largest quantity of meal. Now, whether it is right or not, that is a different topic of debate and discussion. But socio-culturally, that is what is seen in many, if not all, of the Indian families. So, such adult male members had a prevalence of greater than 25% of iron deficiency and other related anemias. Now, this is huge for the group or the subgroup of your society who is supposedly having the best available meal of each and every household. And that and many other factors has led to inclusion of adolescent boys also. The adolescent boys of today are ultimately going to become adult male members of the society tomorrow. Then obviously we have the women of reproductive age. We have, but obviously the pregnant women and the lactating women. So those were the 6 beneficiaries. Now we have the 6 interventions. So we have prophylactic iron and folic acid supplementation, which depends on the age and the dose varies and the delivery mechanism also varies with the age group. Then we have deworming using albendazole tablet. Again, the dose varies depending on the age group that is being catered to. Very importantly, we have this behavior change communication. And what you should again try and relate is that the behavior change communication has also now included topic of delayed cord clamping. Now just think about it. When do we do cord clamping? Cord clamping is done within first few seconds to minutes of life. So our program is not only trying to take care of pregnant and lactating women or adolescents or primary school children or Anganwadi going children, but our interventions, our strategies are trying to take care of iron deficiency and other related anemias as early as within first few seconds or minutes of life. And that is why one of the intervention is delayed cord clamping. Next, we have testing using hospital digital methods and point of care treatment. Now, this is very, very important. You cannot just diagnose and leave the subject as it is. तुम्हें anemia है, but अभी हम कुछ नहीं कर सकते. Come next week, come next month. That is how programs do not work. If you want your program to work, wherever you are diagnosing any health condition, preferably you should be able to at least initiate some form of management then and there itself. Mandatory provision of IFA fortified foods in public health programs. Now, this is also very important. Now, you are going to do BCC to improve the iron content, to improve the iron quality of domestic foods of the population. Obviously, before you tell them to improve the iron and folic acid quality, the places where you are distributing foods, they should be very much fortified in iron and folic acid. So, as an example, as a method of showing that this is so important, mandatory provision of IFA fortified foods in various public health programs. And finally, we have to address the non-nutritional causes which are prevalent in their respective endemic areas. The chief ones being malaria, the various hemoglobinopathies like sickle cell disease, and fluorosis. Now, 6 institutional mechanisms. Now, in the training modules, these were arranged from 1 to 6 in a different order. I have changed their order to make more sense to for better understanding of the viewers and listeners. So first 2 are intra-ministerial coordination and convergence with other ministries. Something which we have already seen. We want to deliver in schools. We want to deliver in Anganwadis. We want to deliver in private sector. Now there are various stakeholders who own how and what goes on in these institutions. So you have to have intra-ministerial coordination within the health department, within the health ministry, and also you want to have convergence with other ministries. Not only ministries, as I said, government, semi-government, non-government, and private sectors. Then we want to develop National Center of Excellence and Advanced Research for Anemia. and also a national Anemia Mukt Bharat unit. This is very important. You need to strengthen the supply chain and logistics. And as I said earlier, supply chain and logistics for testing, supply chain and logistics for treatment, supply chain and logistics for prophylaxis, and also supply chain and logistics for your behavior change communication or your health education activities. And for monitoring and evaluation purpose, there is this proposal of Anemia Mukt Bharat dashboard and the digital portal. So what are the new features of this program? So we are looking for diagnosis and treatment of adolescents. As I said, we have included the boys, and we are looking for this service delivery using the RBSK, that is the Rashtriya Bal Swasthya Karyakram service delivery component. Then we are focusing on delayed cord clamping. We have reduced the elemental iron dose from 100 to 60 milligram, and more importantly, the iron tablets have to be sugar coated. Obviously, that would increase the compliance amongst all the various age groups that we want to cater to. Already discussed fortified foods in the public health programs. Now, the double fortified salt has been there for some years now, but this program says that there will be special focus on this double fortified salt. There is focus on use of digital methods for diagnosis. There would be a dedicated dashboard for Anemia Mukt Bharat, and there would be Jan Andolan through the behavior change communication activities. Now look at normal hemoglobin levels and severe anemia. Now the module talks about mild and moderate anemia levels also. Those who want to have a look, I'll post the link of the module in the description. You can go and have a look, but at least we need to know what are the normal levels for the various groups and under which level we call severe anemia. So for pregnant women and for children 6 to 59 months, that is Anganwadi going children, the normal level of hemoglobin is more than 11 gram per cent. And accordingly, their severe anemia is below 7 gram per cent. So a pregnant female having HB less than 7, and also a child, Anganwadi going child, having HB less than 7 would be labeled as severely anemic. Now then this next age group, primary school children, 5 to 11 years, hemoglobin more than 11.5 is normal, less than 8 is severe anemia. Children 12 to 14 years, or you can call them early adolescents or early teens, and also non-pregnant women who are aged more than 15 years, that is the late teens and the reproductive age women. But when I say late teens, late teenage girls, middle and late teenage girls and reproductive age women, normal levels are more than 12, and severe anemia is below 8 gram per cent. And finally, the men, the boys and men aged more than 15 years, normal level is more than 13 gram per cent, and severe anemia level remains same, which is 8 gram per cent. So as far as the normal levels are concerned, we have 4 different subgroups. One is 11 gram per cent, which is pregnant and children who attend Anganwadis. One is 11.5 gram for primary school children. Then we have a zone of 12 gram per cent, which would be for early teenage children and late teen girls and reproductive age women. And finally, boys aged more than 15 and adult males are supposed to have more than 13 gram per cent of hemoglobin levels. A word about testing using the digital hemoglobin meter. So I'll show the pictures in the next slide. So in brief, the process is that you prick the third or fourth finger. Now, please remember when we say third or fourth, we always count thumb as the first one. So, counting thumb as the first, the third finger becomes the middle finger, the fourth finger becomes the ring finger. Even in our other subjects, we are always taught that generally we go for this ring finger for the process of blood collection via the prick method. The first drop of blood so formed is usually discarded using a cotton swab, and the second or third drop of blood is used. Now, there could be two types of digital hemoglobin meters. We would see the pictures in few minutes. One which use the cuvette and one which use the strips. Now, if you have a cuvette based meter, fill the micro cuvette with the second or third drop of blood and place that micro cuvette at appropriate slot in the digital machine. As I said, some machines may be using strips instead of cuvettes. That depends on the original structure of the hemoglobin meter. So in the top half of the screen, we have the digital hemoglobin meter, which is using cuvette. Now, if you could see this zone, which I am highlighting by the yellow color around it, this is the zone within this hemoglobin meter where that micro cuvette would be placed, and then some a reading like what's here on display 12.8 would flash. In the lower half of the screen, we have a strip based digital hemoglobin meter. So we would have seen glucometers using this same technology. A prick is made, first drop is discarded, second or third drop is used for measurement. A strip is placed directly onto the drop of blood, and the machine would give you the reading. We move on to the iron folic acid profile axis. Now, various groups have different dose and frequency and different delivery point. We will go one by one. First is the 6 to 59 months. The 6 to 59 months are very small children. So the frequency is bi-weekly. 1 ml syrup, because these are young children, will not consume tablet. And the dose is 20 milligram of iron and 100 microgram of folic acid. You remember the first half of the dose is generally iron, which is measured in milligram, and the second half is folic acid, which is generally measured in microgram. Now, microgram traditionally is written as mu g. We don't have mu to write, so either we can write it as ug, which is already there in display, or a better way of writing it is mcg. Mc stands for microgram. Now, what would be the delivery point? So, delivery point for these 6 to 59-month-old children would be through ASHA. 5 to 9-year children, that is the primary school children. Now, just focus on the color of the tab, the center tab, to remember the color of the tablet, the iron folic acid tablet, which these respective groups are going to get as a part of the IFA prophylaxis. So these primary school children get weekly one tablet. The dose is 45 to 400, 45 milligram plus 400 microgram, and this is a pink sugar coated tablet. And where do they get these tablets? So they can get it in schools, or they can get it through ASHA. So those who are school going children will be given through schools, and those who are out of school would be given through ASHA. So a community medicine resident should be able to summarize this kind of delivery points as center-based and community-based. This is a center-based delivery point. The child is going to school. You are using school as a center for delivering your program and giving the child iron and folic acid. And this one is community-based. Even here, if you see, if the ASHA is going house to house, then this would become a community based. And if the ASHA is using Anganwadi center as the point of delivery for IFA, that would become a center based delivery. Moving ahead, 10 to 19 years, school going children. Now, when we are saying 10 to 19 years school going children, we are not specifying the gender. So adolescents, or in other words 10 to 19-year-olds who are enrolled in schools, they are, all of them are going to receive this weekly one tablet of blue sugar coated one, iron ki neeli goli. You may get just a simple neeli iron goli or iron ki neeli goli. What is that iron ki neeli goli? For adolescents, 60 milligram of iron and 500 microgram of folic acid. It is a center based delivery through schools. Now there would be some adolescents, in fact there would can be many adolescents who would be out of schools. So for them, only for girls, when out of school, we are using the gender specific, only for girls, the same dose, same blue sugar coated iron kinili goli, same dose of 60 milligram plus 500 microgram, community based delivery through ASHAs. NPNL women, I hope we all know that NPNL stands for non pregnant, non lactating women. So, in women of reproductive age group, just to specify that they are neither pregnant nor lactating, this abbreviation NPNL is used. Now the iron goli becomes red, iron's red tablet, 60 milligram of iron, 500 microgram of folic acid, community based delivery through ASHA. Pregnant women, now we would be knowing that in first trimester iron is avoided. There could be multiple reasons. One is that the body's demands are not that high. Secondly, there is already nausea and some women have frank vomiting also. This iron has a known side effect of worsening that nausea and vomiting. And thirdly, the teratogenicity status of iron is not that clear. So we avoid iron folic acid prophylaxis in first trimester and we start it from the second trimester. You have to have at least 180 days of IFA prophylaxis in pregnancy. The dose will be same as the NPNL women, 60 milligram of iron, 500 microgram of folic acid, sugar coated red tablet, daily one tablet to be taken. What would be the delivery points? So antenatal clinics can be the delivery points. Antenatal clinics carried out during the village health and nutrition day, or more importantly, antenatal clinics carried out under the Pradhan Mantri Surakshit Matritva Abhiyan. We all would be knowing that this is special ANC checkups introduced pan India to be carried out on a specific day of every month. So those ANC clinics can be used as a delivery point. So again, it is a center-based delivery point for pregnant women. And also for lactating mothers may mean women who are breastfeeding, but for this program purpose, we are only taking mothers who have children in the age group of 0 to 6 months. The dose remains same. Even here also we are talking about 180 days, that is roughly first 6 months after delivery of the baby. Daily one tablet, red sugar coated, same 60 milligram iron, 500 microgram folic acid, and these can be delivered through the village health and nutrition day. Moving ahead, and this is the last slide of part 1 of this video. So we are talking about deworming. Now, there are various kinds of worms that may, cause infestations within a human's gut. And these worms are known to compete for all kinds of nutrients, macro as well as micro. Particularly, they have been blamed for various kinds of micronutrient deficiencies. And one of the most common deficiencies, micronutrient deficiencies, for which intestinal worms have been a known causal factor, is the iron deficiency, leading to iron deficiency anemia. That is why periodic deworming with albendazole is part of this program. Now, we would be knowing that albendazole dose depends on age. So albendazole is contraindicated in the first year of life. It is not to be given till the first birthday of the child. Then from 1 year of age to 2 year of age, albendazole's dose is 200 milligram. And after 2 years of age, the albendazole dose goes up to 400 milligram for the rest of life. So accordingly, for 12 to 24 months age group, we have half tablet, half of what? Half of 400 milligram, that is 200 milligram to be given biannually. Now, the subsequent age groups have been given because they were there in the iron and folic acid. In albendazole, there is no such difference. So if you see from here down till the NPNL women, that is, it may be 2 to 5 years or 5 to 9 years or 10 to 19 years in school or 10 to 19 years out of school, again girls only, and NPNL women, that is non-pregnant, non-lactating women of reproductive age group, that is 15 to 49 years. For all of them, the dose of albendazole remains same, which is one tablet to be given every 6 months, in other words, biannually, and the dose would be 400 milligram. Lastly, talking about the pregnant women. So again, albendazole better be avoided in the first trimester. So this one additional dose that has to be given, it is best in the second trimester, and one dose would be one dose of albendazole 400 milligram to go for a healthier mother and a healthier baby, and to prevent micronutrient deficiencies due to intestinal worms. We would continue this Anemia Mukt Bharat in the part 2. For now, if you like this video, please do not forget to press the like button. More importantly, if you have any comments on the video, if you have any suggestions, please do comment in the appropriate section below. Thank you.